Clinical senates were set up in 2013 to bring a clinical voice and the voices of patients to the NHS, particularly looking at configurations of services, scanning the horizon for new developments, and testing proposals for how services might be delivered to patients. As part of this process, the Wessex Clinical Senate was asked to look at vascular surgery in South East Hampshire. We had two large hospitals, Portsmouth and Southampton, both of whom were providing vascular surgery services. We looked at the configuration of services, and both organisations had challenges. The challenges involve the fact that patients present acutely, and particularly if their aorta has burst, requiring life-saving immediate interventions. Technology was changing, and many of these patients were now being treated by putting stents, wire baskets effectively, up through the blood vessels to stabilise the aorta. And there was a screening programme with the aim of detecting people with abnormal aortas, so-called aneurysms, and operating on these in an elective way prior to them rupturing.
By the time that clinical senates came into being on 1st of April 2013, the reconfiguration of vascular services in South East Hampshire had been under discussion locally for at least 6 years. There was also a new national service specification for adult specialised vascular services and a process for assessing whether local providers met that specification. This included requirements to meet national standards, including population coverage of a minimum of 800,000. Each vascular surgeon needed to have an appropriate arterial workload of 10 abdominal aortic aneurysms, AAAs, per year. There must be at least 6 vascular surgeons employed in each arterial centre. The cardiovascular network, former primary care trusts, clinical commissioning groups, Portsmouth hospitals and University Hospital Southampton had devoted considerable time and attention to consider all possible options for service reconfiguration to achieve the best outcomes for patients. There had been 3 independent panels with national experts during this period. Despite their geographical proximity, there was not a strong history of collaborative clinical working between the two trusts, something that was aggravated by the national policy that encouraged competition between providers. The trusts affected did not agree with Specialised Commissioning's plan for reconfiguration. This led to further difficulties recruiting vascular surgeons and interventional radiologists, as University Hospital Southampton was the major trauma centre and Portsmouth hospitals had the hybrid theatre. There were insufficient surgeons to provide a specialist vascular team 24 hours a day, 7 days a week across both sites. At the time of the recommendations in 2013, Portsmouth hospitals had 3 and University Hospital Southampton had 6 vascular surgeons performing AAA repairs. The Director of Specialised Commissioning asked the Senate Council for views on each of NHS England's 4 proposed solutions. The Senate Council considered these, but recommended a 5th option, that abdominal aortic aneurysms, AAAs, were undertaken at University Hospital Southampton because AAA screening meant this operation was becoming rarer and the trust should work in a network, sharing surgeons, rotas and other services across sites, with plans to address the pre-surgical needs and to prevent the onset of disease in the diabetic population who were more likely to have vascular needs. The Wessex Clinical Senate Council recommendations on vascular surgery were shared with clinical commissioning groups, presented to relevant health oversight and scrutiny panels, and to the Portsmouth and Southampton hospital boards in December 2013. This led to coverage in the local press about the recommendations, which were published in full in the Portsmouth Evening News, and discussion about the role of the Clinical Senate Councils which had recently come into being. The publication of our Senate Council report received widespread media coverage and not altogether positive. This was partly due to the fact that Senates were new and their role was not fully understood. A vascular network, as recommended by the Senate, across Portsmouth Hospitals and University Hospital Southampton was in place by 2015, and the Cardiovascular Clinical Network set aside funding for a project manager. The then medical director, Dr. Liz Mearns, agreed to chair the project board. The change was fully implemented by the 3rd of April 2017 when all major arterial surgery moved site from Portsmouth Hospitals to University Hospital Southampton. Before the service reconfiguration, there were differences in outcomes depending on where the patients presented. We have been able to assess the impact of the project on patients. Annual data is collected by the Vascular Society by surgeon on their operations and published on their website. This is data analysis that doesn't exist for some other types of surgery. The data are presented as percentages, and the data wasn't adjusted for risk. In other words, it didn't take into account whether the patient was older or had serious things wrong with them. The data showed that the combined mortality following AAA repair in Portsmouth and Southampton reduced from 4.2% to 1% between 2013 and 2018. The number of patients undergoing vascular surgery is very small, but when we apply the percentages to the number of people operated on, it shows that 9 more lives were able to be saved following vascular surgery between 2013 and 2018. The number of stents or EVARs as a proportion of total procedures increased to 54% from 48%. This technology enables less invasive surgery. One of the key factors in the success of this project was that there was consistency of involvement with most parties, including the full-time project manager seeing it through from start to finish. As well as the consistency, the frequency of the Vascular Implementation Board meetings and the seniority of those sponsoring and chairing it enabled the project to proceed at pace. A key tenet of the Wessex Clinical Senate Council's recommendations was for clinicians across Portsmouth and Hampshire to start to work together across sites in a network model. This model has since become common currency in vascular services. In the editorial to the March 2018 GIRFT report on vascular surgery, Professor Michael Horrocks notes, "The potential to deliver substantial improvement is why I believe that the crucial next step for vascular surgery is to ensure that this network model becomes the norm, with all providers part of a network and work clearly and consistently distributed between hubs and spokes." The Vascular Implementation Board consisted of consultant vascular surgeons from Portsmouth Hospitals and University Hospital Southampton, Healthwatch chairs or managers, Portsmouth and Southampton Clinical Commissioning Group chief officers, clinical leads or directors of commissioning, divisional directors of operations for all hospitals in Hampshire, Head of Communications and Engagement, NHS England, medical directors from Portsmouth Hospitals and University Hospital Southampton, specialised commissioning representatives, South Central Ambulance. The implementation of the service change was extremely complex as patient safety was paramount. The surgical representative from Portsmouth Hospitals on the implementation group said that the pathways for managing emergency and urgent admissions or attendances at Portsmouth hospitals, especially out of hours, was one of the most difficult parts of the reconfiguration and required the involvement of many different specialties in order to agree how and by whom these patients should be managed. For example, diabetic foot problems requiring urgent attention and management, ischemic limbs, etc. Indeed, this remains one of the areas where there is still considerable challenge across the pathway. The impact on patient mortality, now that the change has been safely managed, is considerable. Portsmouth's mortality rate was 1.8% above the UK average following AAA repair in 2013. But although it was acknowledged that this figure might be misleading as it was not risk adjusted, unlike the data published since 2015, all project participants agreed that continuous service improvement was vital to save as many lives as possible. By February 2017, robust on-call arrangements were in place across sites, and Southampton's hybrid theatre was scheduled for completion at the end of March 2017. The change was fully implemented on 3rd of April 2017, when all major arterial surgery moved from Portsmouth to Southampton. The contractual implications were complex. Historically, vascular activity at Portsmouth was contracted by the Clinical Commissioning Group, despite efforts by Specialised Commissioning to pull it into the NHS England contract for 2014-15. NHS England first needed to negotiate the transfer of vascular activity from the Clinical Commissioning Group to the NHS England contract, which did not happen until the 2016-17 contracts were agreed. The structure of tariffs meant that some vascular hubs nationally were not being paid for emergency work. Some spokes were not being paid for repatriation, or commissioners were paying twice. There was a risk that this could result in blocked beds at Southampton. The network identified that tariffs needed to be reviewed to either incentivise desired pathways and protocols, or the tariff should be paid to the network provider for internal distribution according to a service level agreement. This was a more financially attractive model than all income being received by one organisation. However, in Wessex, there was not a single network provider for all vascular services. Vascular nurses did not transfer to University Hospital Southampton, but there was a transfer of 3 vascular surgeons from Portsmouth hospitals to University Hospital Southampton. This meant that there was minimal disruption to services. An audit suggested that Portsmouth hospitals would need approximately 10 beds available for repatriation, so a split tariff was agreed between Portsmouth and Southampton. Income from activity undertaken at Portsmouth hospitals, such as day case, unbundled radiology and theatre time, remained in the local Clinical Commissioning Group contract. The vascular surgery recommendations in South East Hampshire were one of the first pieces of work we completed as a Senate, and it was to prove crucial to our credibility in the system. Its successful implementation led us to being asked to get involved with a range of other projects. It has also had a positive influence on our ability to recruit Senate Council members.
What you have heard of has been a journey that has been protracted and difficult. Not only organisationally difficult, but difficult for people, for the clinicians involved in the services, for the trust management, and for the population, many of whom had concerns that they might not have access to timely services when they were acutely ill. However, politicians, clinicians, managers and patient representatives have all worked together to bring out a solution that serves people better, that is sustainable, and that assures people that should they need the services of the South East Hampshire Vascular Network, they will have access to the most up-to-date and prompt treatment. And I would like to thank all of those involved in this initiative for their dedication, for their selflessness, and for sharing their ambition to be the very best, because that's what our people deserve.